Hi everyone, and welcome back to our final module of the semester focused on drug treatments and drug court. In this first micro lecture, we will spend time examining efforts to combat addiction and what it means to treat the user who has a disease rather than as a criminal in need of incarceration. We will finish the module by examining the effectiveness of drug courts and how these alternative court programs serve the defendant rather than the system. When individuals are ready to quit using drugs or alcohol, treatment programs exist to help them get clean and sober. Whether it is by choice or because they have hit rock bottom, drug treatment centers work to use proven treatment methods to help break users of their habits. It's not always easy, and relapse is bound to happen for many individuals. Treatment centers are prepared for that inevitability and know how to help patients if and when that occurs. Treatment can take many forms. Some individuals choose to get clean by quitting cold turkey, which is a difficult thing to be sure. Even trying to quit tobacco products cold turkey can be difficult without the aid of items like Nicorette. Alcohol users who quit cold turkey can experience severe withdrawal symptoms that can lead to seizures, coma, or even death if the addiction is too strong or severe. Withdrawal from harder drugs like heroin or oxycodone often require the supervision of a professional who can administer methadone treatments to help wean the individual off of the drug slowly without shocking the system with total withdrawal all at once. It doesn't matter if the user is trying to withdraw from legal or illegal drugs. Licensed treatment providers are equipped with the tools to help individuals withdraw safely from their chosen drugs and to help provide them with the means necessary to learn to stay clean and sober. Again, not an easy task by any means. Part of why drug treatment is so difficult is that the addict is trying to combat two things at once: the physical and the psychological dependence. As you may remember from our early semester discussions, physical dependence suggests that your body has become chemically dependent on the drug in question, and once you metabolize the last dose taken, your body will go into withdrawal. This means that your body is seeking more of the substance in question, craving what it is lacking. Physical dependence can occur with nearly everything out there, from coffee, nicotine, alcohol, all the way through much harsher substances like opioids and prescription drugs. Some substances like marijuana and LSD do not have the same severe withdrawal process as some of the others that I have mentioned, but can have a significant psychological dependence associated with them. Psychological dependence can continue to occur even when the physical dependence is gone. For many users who become physically clean from their substances, they report the deep, intense psychological desire to still use whatever they were previously using. Marijuana is one such drug in which the mental desire to keep getting high often persists for weeks to months after the final use. While again, users can get physically clean, they might need the tools provided in drug treatment centers or in support meetings to help combat the psychological desire. For many, there is a reluctance to acknowledge drug addiction as a disease. Alcohol and drug addictions are both recognized by the American Medical Association and even by the Supreme Court as medical diseases and as statuses that are not punishable by law. For instance, you can certainly charge an individual with possession or even public intoxication, but you are unable to punish someone simply for being drunk or high. The person in question needs to be committing a crime while intoxicated in order for it not to qualify as a status offense. As addiction is recognized as a medical disease, there are professional treatment plans that have been developed by medical providers and that are used as best practices in treating the disease itself. Much in the same way that a treatment provider uses suggested practices for diagnoses of cancer, diabetes, or other illnesses. Addiction affects multiple brain circuits, including those involved in reward and motivation, learning and memory, and inhibitory control over behavior. That is why addiction is considered a brain disease. Some individuals are more vulnerable than others to becoming addicted, depending on the interplay between genetic makeup, age of exposure to drugs, and other environmental influences. When a person initially chooses to take drugs, over time, the effects of prolonged exposure on brain functioning compromise that ability to choose, and seeking and consuming the drug becomes a compulsive endeavor, often eluding a person's self-control or willpower. In the 1930s, when researchers first began to investigate what caused addictive behavior, they believed that people who developed addictions were somehow morally flawed or were lacking willpower. Overcoming addiction, they thought, involved punishing miscreants or, alternatively, encouraging them to muster the will to break a habit. But if we think back to some of the original drugs that people were addicted to, we saw Civil War soldiers trying to treat war wounds and middle-class women who were prescribed opioids for menstrual issues. These are not groups of people who fit the miscreant label. They are people who fought for the side they believed was right or were simply following the advice of their doctors. Obviously, we now know that opioids should not be prescribed for menstrual issues, as there are safer, more effective types of treatment. But at the time, there was limited regulation on even the manufacture of the drugs themselves. To put things into perspective, alcohol wasn't fully recognized as a disease until 1956, and drug addiction wasn't recognized as a disease until 1987. So how do you come up with a treatment plan for something that isn't considered as a disease until nearly a full century later? The answer is that you don't. For many substance users, they were viewed as either weak or being sinful in nature. There was no way to treat sin other than to repent and ask forgiveness. That's not a very effective treatment mechanism for someone who is chemically dependent on opioids or other substances. We know considerably more than we used to when it comes to drug treatment and the proper way to withdraw someone from a specific substance. Of course, it does take some willpower to withdraw from a substance and not give in to using again. However, it's not as easy to just say no as critics claimed it was in the 1980s. The first time our bodies and brains encounter a specific substance that we enjoy, the brain registers the substance as pleasurable. Our brains recognize all pleasures in the same way, whether they originate with a psychoactive drug, a monetary reward, a sexual encounter, or even a satisfying meal. In the brain, pleasure has a distinct signature. The release of the neurotransmitter dopamine in the nucleus accumbens, a cluster of nerve cells lying underneath the cerebral cortex. Dopamine release in the nucleus accumbens is so consistently tied with pleasure that neuroscientists refer to the region as the brain's pleasure center. Once we associate the brain with a pleasurable sensation, we seek to find that experience again and again. If you have a negative experience with the drug, such as experiencing a bad trip on a hallucinogen or getting sick when drinking too much of a specific alcohol, you might not want to experience that again. We are creatures of reinforcement. Negative reinforcements lead us away from those negative experiences, but positive reinforcements tell us that we should seek that pleasurable experience again and again. When it comes to drug use, the likelihood that the use of a drug or participation in a rewarding activity will lead to addiction is directly linked to the speed with which it promotes dopamine release, the intensity of that release, and the reliability of the release. For example, smoking weed will lead you to a quicker high than eating an edible would. Getting high faster would make you want to keep smoking rather than waiting the 30 to 45 minutes it would take for the edible to kick in. This implies that even taking the same drug through different methods of administration can influence how likely it is to lead to addiction. Smoking a drug or injecting it intravenously, as opposed to swallowing it as a pill, for example, generally produces a faster, stronger dopamine signal and is more likely to lead to drug misuse. When I mention the concepts of negative and positive reinforcement, those of you who have already taken the criminological theory class should have perked up a little bit. These concepts are discussed in Aker's social learning theory, which is the CRIJ version, and in other psych-based learning theories. Like all learned behaviors, it takes time to learn to develop the concept and the skill. Part of all addictions come from a trial and error process. For example, you may need a more seasoned drug user to help you navigate the administration process. For most heroin users, it might be difficult to figure out just how much to use at first. You know that overdose is a possibility, and if you've never used it before, you might want to do so in the company of another heroin user. It's not a drug where you can just shoot up the first time and hope for the best. Other drugs like alcohol or marijuana have a lower toxicity level, so they are drugs that you could learn to use more independently. For example, if you drink too many beers and throw up or experience a hangover, that might be all the negative reinforcement you need to not go so hard the next time. The reinforcement is a more singular experience in these cases. However, either way, the positive or negative reinforcement is stored in the memory center of the brain. That combined with the dopamine release makes it more likely that a person will continue to use, thus becoming addicted to a specific drug. Over time, the brain adapts in a way that actually makes the sought-after substance or activity less pleasurable. In nature, rewards usually come only with time and effort. Addictive drugs and behaviors provide a shortcut, flooding the brain with dopamine and other neurotransmitters. Our brains do not have an easy way to withstand the onslaught. Addictive drugs, for example, can release 2 to 10 times the amount of dopamine that natural rewards do, and they do it more quickly and more reliably. In a person who becomes addicted, brain receptors become overwhelmed. The brain responds by producing less dopamine or eliminating dopamine receptors. An adaptation similar to turning the volume down on a loudspeaker when the noise becomes too loud. As a result of those adaptations, dopamine has less impact on the brain's reward center. People who develop an addiction typically find that in time, the desired substance no longer gives them as much pleasure. They have to take more of it to obtain the same dopamine high because their brains have adapted, an effect known as tolerance. At this time, compulsion takes over. The pleasure associated with an addictive drug or behavior subsides, and yet the memory of the desired effect and the need to recreate it, meaning the wanting, will still persist. It's as though normal machinery of motivation is no longer functioning. Once the individual is in the midst of full-blown addiction, drug treatment providers can step in to help break the cycle. But that is so difficult to do because you have to combat both the physical and the mental aspects of drug use. Because our brains remember the feelings of pleasure that the drug brings us, the user must overcome those memories and the feelings of euphoria. That's when relapse is the most likely. About 40 to 60% of people with a drug addiction experience at least one relapse after an initial recovery. While this may seem discouraging, the relapse rate is similar to that in other chronic diseases, such as high blood pressure and asthma, where 50 to 70% of people each year experience a recurrence of symptoms significant enough to require medical intervention. But this only makes sense if we keep framing addiction in terms of a disease rather than as a lack of willpower. This is why it is beneficial for users to find help and support from licensed treatment providers who are trained in this area. Just like you wouldn't try to treat diabetes or cancer on your own, you shouldn't try to treat addiction without a treatment provider or sponsor. Drug use is normally a multifaceted event that can impact every aspect of a user's life. A user's family, friends, career, and more can be impacted by drug use. That's why a proper drug treatment plan also has to focus on these different dimensions as well. Effective treatment programs typically incorporate many components. each directed to a particular aspect of the illness and its consequences. Addiction treatment must help the individual stop using drugs, maintain a drug-free lifestyle, and achieve productive functioning in the family, at work, and in society. Because addiction is a disease, most people cannot simply stop using drugs for a few days and be cured. Patients typically require long-term or repeated episodes of care to achieve the ultimate goal of sustained abstinence and recovery of their lives. Indeed, scientific research and clinical practice demonstrate the value of continuing care in treating addiction, and a variety of approaches have been tested and integrated in residential and community settings. That being said, there is no one-size-fits-all treatment plan. Treatment varies depending on the type of drug and the characteristics of the patients. Matching treatment settings, interventions, and services to an individual's particular problems and needs is critical to his or her ultimate success in returning to productive functioning in the family, workplace, and society. Treatment also needs to be accessible to all drug users. Help should not be limited to those with insurance or the financial means to seek help. Because drug-addicted individuals may be uncertain about entering treatment, taking advantage of available services the moment people are ready for treatment is critical. Potential patients can be lost if treatment is not immediately available or readily accessible. As with other chronic diseases, the earlier treatment is offered in the disease process, the greater the likelihood of positive outcomes. Just as it takes time for addiction to develop, it also takes time for an addicted person to break the cycle and learn to cope without the drugs in their system. This is why some treatment providers allow for patients to seek treatment in an inpatient or residential setting. Research indicates that most addicted individuals need at least 3 months in treatment to significantly reduce or stop their drug use, and that the best outcomes occur with longer durations of treatment. Recovery from drug addiction is a long-term process and frequently requires multiple episodes of treatment. As with other chronic illnesses, relapses to drug abuse can occur and should signal a need for treatment to be reinstated or adjusted. Because individuals often leave treatment prematurely, programs should include strategies to engage and keep patients in treatment. As the infographic on your screen suggests, rehabilitation programs are a stepwise process where first the patient must detox from the drug, meaning this is the time it takes for the drug to be fully metabolized out of the user's system and there is no more active drug in the body. The last dose is completely gone and the user has entered withdrawal. Once physical withdrawal is complete, the patient will enter a short-term residential treatment program if they have the time and ability to do so. This allows the user to be immersed into treatment in a safe, secure place where providers are able to help the individual on a one-on-one basis. After the first 30 days, the patient might be well enough to leave the treatment facility and continue seeing an outpatient treatment provider. Others might need more time in the facility and can stay upwards of 90 days where they are able to receive treatment over a longer period. But the outcomes should always be the same, that the patient receive enough treatment to be released back into the community and be home with the tools they need to not relapse once they return. But again, the idea that either way, they are well enough to continue treatment with an outpatient provider. Behavioral therapies, including individual, family, or group counseling, are the most commonly used forms of drug abuse treatment, whether the patient is in an inpatient facility or is seeking help from an outpatient treatment provider. Behavioral therapies vary in their focus and may involve addressing a patient's motivation to change, providing incentives for abstinence, building skills to resist drug use, replacing drug-using activities with constructive and rewarding activities, improving problem-solving skills, and facilitating better interpersonal relationships. Also, participation in group therapy and other peer support programs, during and following treatment can help maintain abstinence. Group treatment programs allow the user to be held accountable to others and to realize that they are not alone in their addictions, that others are experiencing the same struggles that they are, and that they are not isolated in their desire to get clean. Behavioral treatments can often coincide with maintenance medications like methadone or naltrexone. Research suggests that those individuals fighting opioid addiction can find success using a maintenance medication in combination with behavioral treatment interventions. Not all drug users have the financial ability to use these maintenance medications. So sometimes, depending on your state, there may be financial assistance programs available to these lower income individuals. What is important to remember that when it comes to drug treatment plans, there is no one-size-fits-all for drug-addicted persons. Everyone has a different experience, different issues to combat, and what might work for one person may not work for someone else. It is all right for treatment plans to be adjusted for people based on their life circumstances across individuals, and even for a specific individual over time. While we are certainly creatures of habit, we are also creatures capable of change. What might work for us in the beginning might not work for us 3 months in. Or perhaps a specific event has taken place during treatment, such as the loss of a job or the death of a loved one, which may require a treatment plan adjustment. A patient may require varying combinations of services and treatment components during the course of treatment and recovery. In addition to counseling or psychotherapy, a patient may require medication, medical services, family therapy, parenting instructions, vocational rehabilitation, and/or social and legal services. For many patients, a continuing care approach provides the best results, and the treatment intensity varying according to a person's changing needs. When a relapse occurs, or if there is a criminal justice intervention, it is important to note that while treatment might not be voluntary all the time, it doesn't mean that it can't also be effective. For example, sanctions or enticements from family, employment settings, and/or the criminal justice system can significantly increase treatment entry, retention rates, and the ultimate success of drug treatment interventions. When criminal justice system interventions occur, and they routinely do for millions of people, we know that it could be just the breaking point an individual needs to get back on track with their treatment plans. From our discussions throughout the semester, we know that millions of drug users are incarcerated every single year for smaller personal use amounts of specific drugs. For first-timers, meaning those without criminal records but who might be arrested for drug possession the very first time, there are alternatives out there to help these people through the use of specialized courts which rely heavily on drug treatment. This is going to bring us to the end of the first micro lecture for the module, which focused exclusively on drug treatment. You might have noticed that I segued into criminal justice interventions and the use of specialized courts to help the individuals who are new to the system. That's where we will pick up with the start of the second and the final micro lecture of the module. During that time, we will specifically focus on drug courts and their role in trying to help the addicted person rather than to criminalize the addiction. I will see you back here for that discussion.